Great. Good morning, everyone. Welcome to the final day of the San Antonio Breast Cancer Symposium. Excited about the poster spotlight discussion today. We'll be reviewing translational approaches, evaluating resistance heterogeneity in ER-positive, HER2-negative breast cancer first, and would like to welcome Dr. Joe Chien, Professor of Medicine at UCSF. Dr. Chien.
Good morning. Thank you to the meeting organizers for inviting me to discuss these 4 abstracts. These are my disclosures. The 4 abstracts can be organized into 2 key themes. The first, identifying mechanisms of CDK4/6 inhibitor resistance in metastatic breast cancer. The second is evaluating tumor heterogeneity and endocrine resistance in patients receiving neoadjuvant endocrine therapy. Let's start with the mechanisms of CDK4/6 inhibitor resistance. CDK4/6 inhibitor resistance improves overall survival in patients with hormone receptor-positive, HER2-negative metastatic breast cancer, as well as patients with high-risk early breast cancer. If you look at the clinical subsets from these landmark studies, both in the metastatic and the early-stage setting, you see that all clinical subsets benefit. However, in MONALEESA-2, we know that the clinical benefit rate is 80%, and thus 20% of patients will progress up front. And while the response to CDK4/6 inhibitors is broad, half patients will progress after about 2 years. In the high-risk early breast cancer population, 14% of patients will have a distant recurrence within the first 5 years. A number of studies have shown disease post-CDK4/6 inhibitor is highly resistant and associated with short progression-free survival. The EMERALD study, which enrolled nearly 500 patients randomizing to elacestrant versus standard of care endocrine therapy, all of the patients had received prior CDK4/6 inhibitor. And you see that at the first restaging, 40% of patients in both arms progress. And thus, the PFS in the standard of care endocrine therapy arm was less than 2 months. We see similar results in the CAPItello 291 study, comparing capivasertib and fulvestrant versus placebo and fulvestrant. You see in the cohort that had all received prior CDK4/6 inhibitor that the PFS in the control arm was also short at 2.6 months. Thus, identifying potential mechanisms of both primary and acquired resistance to CDK4/6 inhibitors, and more importantly, identifying potential therapeutic targets is a high priority. Shown here is a select list of biomarkers that have been associated with mechanisms of resistance to CDK4/6 inhibitors in metastatic trials or from samples from metastatic patients. While many of these biomarkers have been associated with worse outcome in patients with CDK4/6 inhibitors, none of these biomarkers has been validated to be predictive of treatment benefit or lack of benefit. Dr. Vingiani and co-authors hope to change this. Today, we see a sneak peek into early results from the UNDERSTAND trial, which is a prospective, ongoing, longitudinal observational study in patients with metastatic breast cancer on first-line CDK4/6 inhibitor. This is a translational study where patients will undergo baseline biopsy of the tumor and plasma collection, as well as at the time of progression. Investigators are conducting a multi-omics approach, including genomics, transcriptomics, and epigenetic studies, as well as digital spatial pathology analyses. Today, the authors present data from their single-cell RNA-seq analysis in 20 patients that have baseline T0 collection, and 2 of these patients have had progression with a biopsy collected at the T1 progression time point. Key results include longitudinal single-cell RNA-seq analysis. Shown here are results from 2 patients with matched T0 and T1 time points. And you can see that the baseline cells, shown here in turquoise, cluster separately and distinctly from the T1 time point cells at progression. You see that the cells at progression, shown here in darker blue, at the time of progression, they have downregulation of CCND1. And then over time, through algorithms looking at the longitudinal acquisition of mutations, you see upregulation of alternate cell cycle pathways like CCNB1 and CDK1 in a small subset of subcloned cells that are resistant. These studies, longitudinal analyses of single-cell RNA-seq, are able to show us distinct adaptation mechanisms to CDK4/6 inhibitors. The authors also present cell-cell communication analyses, shown here on the right, from tissue from different metastatic sites, shown here are liver and lymph node. And you can see that the communication between tumor cells and other cells in the tumor microenvironment are distinct and different depending on the site. And this may give us a window into why the prognosis and response is different between visceral and non-visceral metastases. Results from this abstract include a small number of patients. Only 2 patients had tissue at the time of progression, so these results are certainly hypothesis generating and exploratory. However, I think it highlights the potential power of the UNDERSTAND trial, and it addresses many of the limitations of prior translational efforts. For example, the prospective collection of matched tissue and plasma at baseline and at progression is rare. It allows for the assessment of both primary and acquired mutation at the patient level. It also addresses concerns about archived tissue from other prior studies being from primary breast tissue, as well as baseline tissue having intervening therapy between the tissue collection and the time of CDK4/6 inhibitor exposure. Single-cell analyses can distinguish whether co-occurring mutations are in the same tumor cell or in a contemporary subclone. This is important because if you have co-occurring mutations in the same cell, it may be important to target both of those mutations simultaneously. Individual patient-level data will help identify rare mechanisms and mutations that are difficult to detect in pooled analyses, and cell-cell interaction analyses can better elucidate the role of the tumor microenvironment in resistance. Moving on to the second abstract presented by Dr. Kudo and co-authors, they present a number of in vitro, in vivo, and translational studies that characterize the role of TP53 loss of function in CDK4/6 inhibitor resistance. They first look at a cohort of nearly 500 patients from MSK, patients receiving first-line CDK4/6 inhibitor and endocrine therapy. And they showed that patients with baseline TP53 loss of function variants, which makes up about 28% of the population, had shorter progression-free survival compared to patients who had wild-type P53 at baseline. They also looked at samples from the Feline study, which is a neoadjuvant endocrine study of letrozole plus or minus ribociclib. And they showed that while nearly all patients suppressed the Ki-67 at the 2-week time point, those that had baseline mutant P53 were more likely to have Ki-67 rebound at the time of surgery compared to patients that were wild-type P53, suggesting that these cells are re-entering the cell cycle. I invite you to take a closer look at the poster, to look at the in vitro and in vivo data. I will summarize it here by saying the authors show that P53 loss of function leads to tumor regrowth after long-term cell culture on CDK4/6 inhibitors. This is due to the loss of the DREAM complex. The DREAM complex is P130 and E2F. The P130 is actually part of RB1, and when that is lost due to loss of P53 and increased CDK2, which increases phospho-130, then the cell re-enters the cell cycle and moves away from senescence. The authors show that if you combine inhibition of CDK2 and CDK4/6 in P53 knockout cell lines, this results in long-term growth suppression, and you can increase senescent phenotypes. So this supports the combination of CDK2 inhibitors along with CDK4/6 inhibitors as a potential way to bypass resistance. So there are a number of CDK2 inhibitors that have entered clinical development. The one that is further along is tactociclib. Phase 1 monotherapy data were presented at ASCO last year in 29 patients with metastatic disease. All of these patients had prior CDK4/6 inhibitor. And they showed a partial response rate of 19%, a disease control rate of 61.5%. This was relatively well tolerated. The grade 3 or higher neutropenia rate was 14%. I will, however, highlight that the grade 3 fatigue rate was 20%, and that should be followed. At ESMO this year, phase 1 combination data of tagdociclib plus the CDK4 inhibitor atirmociclib were presented. And at the doses that are being expanded, you see that this combination is actually very well tolerated with grade 3 neutropenia rates that are lower than what we have seen with other CDK4/6 inhibitors. This was also a very heavily pretreated population that had all received prior CDK4/6 inhibitors, and objective response rates were 28%, and median PFS 8.3 months. And this really is exciting as it's supporting the combination of more selective CDK inhibitors as a way to reverse resistance to CDK4/6 inhibitors, and it may be more tolerable. Dr. Chibley and co-authors report a novel, we're moving to early stage now, they report a novel method for identifying 8 stemness gene expression signatures. They use 8 stemness gene expression signatures and looked at the expression in the Opportune study. The Opportune study is a neoadjuvant endocrine study of anastrozole plus or minus a PI3 kinase inhibitor, pictillisib. Of the 8 stemness gene expression signatures, the Schatz consensus signature was the one that was the most selective and tumor specific. They looked at the expression of that particular signature in baseline tumor samples from the Opportune study and showed that the baseline samples that had higher stemness was associated with resistant tumors to neoadjuvant endocrine therapy. And resistance here was defined as Ki-67 less than 2.7% or complete cell cycle arrest. And while luminal B tumors had higher stemness at baseline compared to luminal A, this was not statistically significant. There was no difference in baseline stemness based on PIK3CA mutation status. And they looked at this in the feline study as well. Again, remember, this is the letrozole plus or minus ribociclib. They saw no significant difference in stemness between responders and non-responders in either cohort. The authors demonstrate a novel method for identifying breast cancer stem cells using single-cell RNA-seq data. The advantages of using single-cell RNA-seq over other methods such as IHC and FACS include that you can assess multiple biomarkers at once, improve quantification, identify rare cells, and then the results can be readily transferred to spatial transcriptomics. The authors show baseline stemness was associated with lack of response to neoadjuvant endocrine therapy. This needs to be further assessed in larger cohorts, and I think it would be great to assess that in cohorts with higher incidence of cancer stem cells, such as the triple-negative breast cancers. Also, does stemness fraction change after neoadjuvant endocrine therapy? There have been some reports that you can increase stemness after neoadjuvant chemotherapy. And does post-treatment stemness associate with response? It's important to know that it's important to know how response is defined in correlative studies of neoadjuvant endocrine therapy. Currently, Ki-67 and PEPI score are the only endpoints shown to be prognostic for recurrence. However, many trials use a wide variety of primary endpoints shown here. So it's important to consider what is the definition of response when interpreting correlative biomarkers of response. Dr. Kleijn and colleagues report correlative studies from the POETIC trial. The POETIC trial enrolled nearly 4,500 patients that were randomized to 2 weeks of preoperative AI versus not, and found that patients who did not suppress their Ki-67 after 2 weeks of AI had worse outcomes and higher recurrence. So the authors first took a subset of the POETIC patients, 367, divided them into good responders or poor responders based on Ki-67 response, and then used RNA-seq to further divide the poor responders into ESR1 high expression and ESR1 low expression. And they show that patients that were good responders were luminal A and luminal B based on PAM50 subtype. This is not surprising, but what's interesting is that all of them switched to luminal A subtype after 2 weeks of AI therapy. The poor responding ESR1 high tumors, also mainly luminal A and B, had far less switching and some switching from luminal to non-luminal subtypes. And then the poor responder ESR1 low subtype were nearly all non-luminal subtype to begin with, and also very little switching. And then when looking at proliferation and estrogen response expression, you see in the poor responding ESR1 high tumors that the estrogen response signaling is suppressed and the proliferation gene expression is not suppressed as much. And this suggests that this group of tumors, while still estrogen dependent, the estrogen signaling is not the primary driver of proliferation. So this abstract highlights a number of clinical questions. Can molecular characterization help inform treatment decisions? In this study, all good responding tumors switched to luminal A subtype. Are these the tumors that will do well with AI alone? We know that luminal A subtype tumors is associated with good prognosis. However, long-term prognostic significance of subtype switching is not clear. We also need longer follow-up of POETIC. We need to see whether the 2-week Ki-67 is prognostic for late recurrence beyond the 5-year time point. The poor responding ESR1 low tumors were mostly non-luminal. These tumors likely benefit from chemotherapy. This was the experience in I-SPY2, where hormone receptor positive HER2 negative tumors with lower ER was associated with mammaprint high 2 and basal subtype, and these tumors had a higher PCR rate after neoadjuvant chemotherapy. And finally, the poor responding ESR1 high tumors did not suppress proliferation genes as much as estrogen response genes. Are these the tumors that benefit the most from CDK4/6 inhibitors? And this is a critical question to ask and answer right now as we broaden the indication for adjuvant CDK4/6 inhibitors. We want to identify who will benefit and who will not benefit in order to spare patients the toxicity if they do not benefit. So to conclude, identifying therapeutic strategies to reverse CDK4/6 resistance is a major priority. Technology is becoming increasingly sophisticated, allowing for assessment at the single cell level and giving insight into how resistance evolves over time. These approaches have the potential to inform combination and sequencing strategies in the metastatic setting and can further characterize the heterogeneity of early-stage HR-positive, HER2-negative disease to potentially guide treatment decisions. Thank you to all the authors for uploading your slides early and answering all my questions. Congratulations. Thank you.
Invite the authors to come on the stage. We'll open it up for Q&A. You can come to the mic and ask a question. We'll get questions virtually as well. So we have some questions online. I'll start with the first one. This is about the last poster that was discussed. The question is, could you precisely define how ESR1 low was included in the trial? Is there kind of a cutoff for ESR1 low?
Thank you for that question. So the definition of the ESR1 low was done after the trial had concluded in a publication published by our group last year. So this was based on the bulk RNA-seq expression in the baseline samples.
So just building on this, the team demonstrated that if you have Ki-67 suppression, there's associated with, that was a good responder, and then you had the other group that was called the non-responder or less response. But this was with AI. Would you expect similar results with, say, tamoxifen or SERDs, or would that be different?
With different types of treatment than aromatase inhibitor, you mean?
That's correct.
Well, that would be speculation on my part. I don't think I can answer that as a non-clinical researcher.
It'll be interesting to see as we have additional agents if this is specific to NAI or this is a general mechanism.
Yeah, that would certainly be very interesting to see, and I think the type of analysis we've done would be, very well ported to different studies for in that, as long as there's this, matched samples.
There's a question about microphone 1.
Way over here. Hi. I have a question about the first poster that was presented. It seems like one of the mechanisms that you showed that was involved in cell cycle reentry and the resumption of proliferation response after CDK4/6 inhibitors was the upregulation of cyclin B and CDK1. And I'm just curious from a mechanistic level how an upregulation of these G2M effectors would reverse a G1 arrest induced by CDK4/6, and if instead this simply reflects cells, more cells being in the cell cycle and expressing cyclin B and just being in G2.
Yes, thank you for the question. Actually, what you see is absolutely correct, and what I can add is that within the same patient we see multiple mechanisms of bypassing CDK4/6 inhibition. So this is extremely quite interesting because we can, with these elements, overcome the theory that one patient progresses just thanks to one single escape mechanism, but we saw that multiple mechanisms actually are there within the same patient. And of course, we are going to plan some mechanistic experiments to validate what we found, yes. Thank you so much. We are at the very beginning, so we are also designing preclinical experiments to validate our findings.
On this point, there was discussion, and we'd love to hear from Dr. Chien as well, about CDK2 and CDK4 in this circumstance. So the question is, do you think P53 would be a biomarker for selection, and should it be P53 loss, or can you look at P53 mutations as well? And should this be in the post-CDK4/6 setting, or would you consider actually upfront setting when combining CDK2 and 4 from both?
Upfront means the
First-line setting in terms of
first-line setting. Yeah, we didn't assess which timing is the best. All we experiment was started from the beginning. The combination was performed at the beginning, but we need to see in vivo which timing is the best for the addition of CDK2. But so far, when we think about there's a cell cycle re-entry in P53 mutant, so I think the first line combination might be better, but we need to do preclinical experiment to prove that. So P53 loss might be a predictive marker, not prognostic factor. Predictive marker for CDK2 inhibitor addition in clinical trial.
I think it's definitely not ready for that at this time. I think it would be first very interesting to look to see whether patients with P53 mutations who get CDK2 inhibitors, their outcomes are better than what we are seeing currently with P53 mutations, where we see that they generally have a worse prognosis. So I think that would be the first step to see if it changes the prognosis, and then doing further biomarker work to see if it could be predictive. But at this time, not yet.
And those results were not presented at ASCO or ESMO when you had the CDK2 results. No one has shown clinically correlation between P53 mutation and response to CDK2.
Correct. That, to my knowledge, yes.
Another question online, what was the correlation of Ki67 in initial biopsy and surgical specimen without usage of AI? We know that Ki67 is heterogeneous and there could be discordance. This was for the neoadjuvant biomarker when they were looking at Ki67. What was the correlation between initial and surgical specimen?
I expect this is a question for me. I can't remember looking into this, to be honest. I'm not sure we had the Ki60. So the correlation between baseline and surgical Ki67 scores.
Correct, in the biopsy and surgical specimen.
So this is the definition of the good and poor responders. So this really is the marker of whether the patients in this study were included in the good responders or the poor responders. And so patients for which the Ki67 in the surgical sample was much lower then in the baseline were classified as poor responders.
Question on microphone 1.
I have 2 questions, if I may. My first question is, does P53 increase as upon progression? I think I heard 27% initial, and then does it go up over time?
Thank you for your question. Yeah, we didn't assess the acquired P53 mutation, but yes, we think it will be increased. So we need to see the over time P53 mutational status, but this is metastatic setting. I'm thinking about ctDNA might be the good option to follow the P53 status. But in this study, we just see the pre-treatment P53 mutation. Thank you.
Thank you. And one other question, and that relates to, we have CDK246 in the clinic, of course, with abemaciclib. So I'm just wondering, are we seeing better outcomes for patients with P53 loss in those in that setting where you might say, well, that might be in a more appropriate drug to give? So is there any correlation, or has anyone looked at the performance of abemaciclib with regard to a P53 LOH?
I'm sorry, I missed the question. So can you?
So my question is
yes.
whether or not abemaciclib may have an advantage over other CDK4/6 inhibitors because it blocks CDK246.
Okay. Oh, thank you so much. So as you pointed out, abemaciclib have CDK2 and 9 and 4/6. So I think the same thing, and I performed the experiment with ribociclib, more pure CDK4 and 6, and we see the same thing. So I think this CDK2 effect, inhibition effect, is not come from abemaciclib itself. So I think it is inhibited by P21 because upon CDK4/6 inhibitor treatment, P21 is moved from CDK4 to CDK2 immediately. So the main suppressor of P130 is not abemaciclib itself. It is P21. It's indirect effect.
Thank you.
Thank you.
Excellent. Great. I would like to thank the panel. Thanks so much for joining. We'll move to the second session.
Thank you.
So the second session is on antibody-drug conjugates, and we'd like to welcome Dr. Barbara Pistilli from Gustave Roussy, France.
Good morning, everybody. Thank you very much for the invitation to discuss these 3 very interesting abstracts. So these are my disclosure. So the 3 abstracts that I'm going to discuss in the next 15 minutes are focused on determining the key mechanism of resistance to antibody-drug conjugates, with 2 main purposes that are, on one side, to define the new treatment strategies to overcome ADC resistance, and on the other side, to identify biomarkers for optimal patient selection. So starting from the first abstract, enhancing TDXD efficacy in HER2-positive breast cancer resistant to HER2 ADC by non-biased kinase-related target screening from Dr. Lee and colleague. The author tried to address in this abstract the question how to overcome resistance to anti-HER2 directed antibody-drug conjugates, particularly focusing on trastuzumab deruxtecan. And here they start from a clinical observation Indeed, in tumor sample of patients exposed to trastuzumab deruxtecan, they observe a reduction in the expression of RBB2 and the upregulation of DNA repair pathway. This is the reason why they explored these two potential mechanisms of resistance in preclinical model. And indeed, they found in trastuzumab deruxtecan resistant, but also in TDM1 resistant cell lines, a lower target expression, that means a lower RBB2 and a lower HER2 protein expression as compared to parental cell. They also performed the gene set enrichment analysis in TDXD-resistant cell lines, so demonstrating an activation of DNA repair pathway. And in a very interesting way, they also, as a further step, they performed a wide synthetic lethality RNA interference screening, selecting ATR gene as a gene mediating resistance to TDM1, but also to trastuzumab deruxtecan. And they combined elimusertib, that is an ATR inhibitor, with trastuzumab deruxtecan, demonstrating synergistic activity of this combination in cell lines, but also in CDX model of TDXD-resistant and TDM1-resistant cell lines. So they concluded that the combination of a DNA repair pathway inhibitor with TDXD holds significant potential to enhance the therapeutic efficacy in patients with breast cancer. I think that this is a very interesting approach, and this is an approach that we already know a little bit. Indeed, we know that the combination of DNA damage response inhibitor, such as PARP inhibitor, ATR inhibitor, with ADC carrying topoisomerase 1 inhibitor, can provide a synergistic efficacy that is related to the synthetic lethality effect. However, I think that this abstract raises a couple of questions. The first question is, does the combination of an ATR inhibitor with TDXD overcome resistance or just enhance the efficacy of TDXD? And we know that there have been some preclinical studies that have combined, for example, PARP inhibitor with sagituzumab govitecan, another ADC carrying a topoisomerase 1 inhibitor payload, showing an increase of the antitumor effect of sagituzumab govitecan through the synthetic lethality effect, but this model were no sagituzumab govitecan resistant. And in the abstract that we are discussing here today, we don't know how TDXD resistant was obtained in these cell lines through a continuous exposure, pulsed exposure with fixed or increasing dose, one-step selection. And if we look at the clinical data that we have so far, we can see that there has been a very recently published study that in a very elegant way combined sagituzumab govitecan with talazoparib in 30 patients with triple-negative breast cancer, demonstrated the remarkable efficacy of this combination, but these patients were not previously treated with a topoisomerase 1 inhibitor. And indeed, to try to address this question, is this combination able to overcome resistance or just enhance the efficacy of the topoisomerase 1 inhibitor payload? In a phase 1b/2 study that we are conducting, that is Icarus Breast 02, that combine TDXD plus olaparib in patients resistant to trastuzumab deruxtecan. So I would say that we still need to determine if the synthetic lethality effect obtained by the combination of a topoisomerase 1 inhibitor with a DDR inhibitor overcome resistance to a topoisomerase 1 inhibitor payload or just enhance its efficacy. The second question that is raised by this abstract is how can these doses in preclinical models be safely used in clinics? Indeed, in this abstract, we see high doses of TDXD and of elimusertib. We know that these cell lines are supposed to be particularly sensitive to DDR inhibitors, and we also know that the maximum tolerated dose is much higher in mouse as compared to humans, and this is particularly true for the ADC because of the differential target expression on healthy tissue, because of the greater payload tolerability in mouse models. And on the other side, from a clinical point of view, again, we know that elimusertib and TDXD can have an hematological overlapping toxicity, and some of the trials that have combined sagituzumab govitecan with a PARP inhibitor with a concurrent schedule have been discontinued because of the unacceptable myelosuppression. However, the combination of sagituzumab govitecan with PARP inhibitor in the study that we have just seen in the previous slide with the sequential schedule seems to have a more manageable safety profile. So I would say a very interesting approach. However, doses and schedule could be an issue when we combine a topoisomerase 1 inhibitor ADC and a DDR inhibitor because of the potential overlapping toxicity. So moving now to the second abstract, that is ARIDA1A as a novel regulator of TROP2 ADC efficacy in TROP2 low hormone receptor positive breast cancer from Dr. Ogata and colleague. Here the author tried to address the question, is ARIDA1A loss a biomarker of response to sagituzumab govitecan in HR-positive breast cancer? And they start again from an observation that ARIDA1 expression negatively correlates with TROP2 expression on a wide range of HR-positive, HER2-negative breast cancer cell lines by Western blot. They clearly demonstrated this negative correlation. But they also demonstrated that ARIDA1A negatively co-regulates TROP2 expression. Indeed, ARIDA1 known in ARIDA1 wild-type breast cancer cell lines increased TROP2 mRNA and protein expression. And on the other side, the ARIDA1 plasmid transfection in ARIDA1 mutant breast cancer cell lines, so an overexpression of ARIDA1 was associated with the reduced TROP2 mRNA and protein expression. And in a very elegant way, they also combined the ATAC sequencing and RNA sequencing analysis of TAXTD2, that is the gene that code for TROP2 on the chromosome 1, and they could demonstrate a higher TAXT2 transcription in ARIDA1 knockdown cell lines as compared to ARIDA1 wild-type cell lines. And so they hypothesized that this higher transcription is related to a greater chromatin accessibility and transcription factor binding. So the conclusion of the author here is that ARIDA1 mutation or loss of function may serve as a potential biomarker for predicting the efficacy of sagituzumab govitecan in HR-positive, HER2-negative breast cancer. However, further validation is required. I would say that is a very interesting hypothesis, but again, it raises some question. The first question that comes to my mind is what is the function of ARIDA1A, particularly in HR-positive, HER2-negative breast cancer, and why ARIDA1A loss could increase TAXTD2 chromatin accessibility and expression in HR-positive, HER2-negative breast cancer. So ARIDA1A mutation are the most common alterations of the SWI-SNF complex in HR-positive breast cancer. And ARIDA1 code for a nuclear protein that is part of this complex. And what is the work of this complex? This complex remodels the chromatin structure, so regulating the transcription factor binding. This is the reason why the question can be here, how ARIDA1 loss can increase the chromatin accessibility and the transcription of TAXTD2, and maybe further analysis such as chip sequencing Western blot in this abstract can address a little more this question. However, on the other side, we can consider a large study, a large analysis that have been published a couple of years ago that have evaluated ARIDA1 loss in HR-positive, HER2-negative breast cancer cell line, but also tumor sample. And here the author demonstrated that ARIDA1 loss was associated with endocrine resistance, particularly to SERDs, but also to decreased or increased chromatin accessibility across the different sites, mostly loss of accessibility. And in a very interesting way, they also demonstrated that ARIDA1 loss was associated with a upregulation of basal-like and stemness gene sets and downregulation of luminal subtype genes. So I think that we can say that the switch to a basal-like phenotypes after ARIDA1 loss could be potentially associated with an increased TROP2 expression. We know very well that TROP2 is more expressed in triple-negative breast cancer tumor, in more aggressive tumor, but for sure further analysis are necessary. The other question that is raised by this abstract is if ultimately by increasing the expression of TROP2 we can increase the activity and the efficacy of sagituzumab govitecan. So what are the evidence that we have so far? There are some in vitro studies that have demonstrated that a higher TROP2 expression can increase sagituzumab govitecan internalization. And there is also this very elegant study recently published that evaluated an epigenetic modulation of TROP2 expression through DNA methyltransferase inhibitors and histone deacetylase inhibitors, showing that a higher TROP2 expression through an epigenetic modulation was associated with increased sagituzumab govitecan activity. And again, from a clinical point of view, what we know from this large phase 3 study, TROPiCS-02, conducted with sagituzumab govitecan in patients with HR-positive, HER2-negative breast cancer, that the patients with low absent TROP2 expression seems to benefit a little less of sagituzumab govitecan as compared to the patients with a higher TROP2 expression. So I would say higher TROP2 expression could improve sagituzumab govitecan efficacy. However, we have to remind that we don't still have a threshold for TROP2 expression in clinics. And now moving to the third abstract, the last but not, for sure not the least of this section, that is mechanism of resistance to trastuzumab deruxtecan in breast cancer elucidated by a multi-omic molecular profiling by Dr. Slade and colleague. Here the author tried to address the question, what are the key mechanisms of resistance to TDXD in clinics? And they start from a huge population, almost 2,800 patients with breast cancer, with a wide range of HER2 expression, as you can see here, and the combined RNA sequencing on breast cancer sample collected before or after exposure to TDXD by focusing on 86 preselected genes, most of them related to ADC resistance, particularly target antigen dimerization, ABCC transporter, endocytosis pathway, and the combined RNA sequencing data with clinical data obtained by insurance claims. What they observed is that ABCC1 is one of the 5 genes with the highest expression associated with overall survival in pre-treatment sample just after RBB2 and K67. And in a very interesting way, they also showed that ABCC1 is not associated with HER2 expression, whereas high ABCC1 is associated with shorter TDXD-related overall survival. And particularly when they look at the population of the patients with HER2-low breast cancer, a shorter TDXD-associated overall survival was observed in the group of patients with high ABCC1 expression. So the author here concludes that the clinical outcome of patients treated with TDXD is for sure a function of HER2 expression, but also potentially of the expression of the key drug efflux pump, ABCC1. I would say this is a very interesting finding, but again, a couple of questions that are raised by this abstract. The first one is ABCC1 overexpression a specific biomarker of resistance to TDXD, or in general of a different type of systemic therapy, and particularly of chemotherapy? Here the author clearly demonstrates with the univariate Cox regression analysis that high ABCC1 expression is associated with the shorter TDXD-related overall survival, where TDXD overall survival seems to correspond to time to treatment failure. But what is ABCC1 or MRP1? It's a member of ATP binding cassette family transporter. So it is associated to resistance to several anti-cancer therapy, increasing the flux from the cancer cell of different compounds, chemotherapy such as vincristine, doxorubicin, but also target therapy. And it is also known as a biomarker of poor prognosis in several cancer types, including breast cancer. And what we know so far are some mechanisms of resistance to trastuzumab deruxtecan, HER2 heterogeneous expression, altered binding of TDXD, payload inefficacy, But among the different mechanisms of resistance to trastuzumab deruxtecan that have been described so far, we didn't know a potential overexpression of a flux transporter. However, if we look at other preclinical data, we can see that upregulation of other efflux transporters such as ABCG2 has been described in sagittuzumab govitecan resistant cell lines, so 2 cell lines resistant to a topoisomerase 1 inhibitor payload, and an upregulation of ABCC1 efflux transporter has been described in TDM1 resistant cell lines. In addition, the author tried to address the question here if ABCC1 overexpression can be an acquired mechanism of resistance to TDXD. And indeed, by comparing mutation rates in pre- and post-treatment sample, they could find a higher rate of NRF2 mutation and CAP1 mutation in post-treatment sample as compared to pre-treatment sample. And they hypothesized that this deregulation of NRF2 CAP1 pathway can determine an overexpression of ABCC1. And indeed, this NRF2 CAP1 pathway is known to be a pathway that plays a key role in metabolic reprogramming after an oxidative stress and can indeed regulate and upregulate the expression of multiple genes against xenobiotics, including ABCC1. So I would say ABCC1 overexpression is for sure one of the mechanisms, the biomarker of resistance to several anti-cancer therapies, but further preclinical and clinical analysis are warranted to establish the role in TDXD resistance. So in conclusion, I think that these are very important abstracts because they generate important approach and hypothesis, new finding that can be explored in the future to better understand the mechanism of resistance to next generation of antibody drug conjugates. And with this, I would like to congratulate all the authors for this important first step in exploring a bit further the mechanism of resistance to novel ADC. And I would like to thank all my colleagues at Gustave Roussy that work on the ADC program, and particularly the colleague that provided valuable insights in the preparation of this discussion. And thank you for your attention.
Have the authors on the stage. Just can come up to the microphone. If you have a question, you can send your questions online as well. Microphone 3.
Thank you. Very interesting data. I have a question to Dr. Slage. What do you think from the hypothesis of the regulation of these transporters? What does that mean for sequencing of treatments? And then because you have in some cases data before and after, does that affect a next treatment, right? Certainly if these are small molecules or other drugs that you think that they will be affected by these increased efflux.
So those are great questions. From a sequence standpoint, this is, I think, going to be determined in large part in clinical practice as a result of phase 3 trials. And I think the suspicion of many in this audience is that trastuzumab deruxtecan is going to become routine first-line therapy for HER2-positive disease in the next few years. And to a certain extent, that may solve the sequence question. In terms of what our work actually does in terms of identifying that, I mean, my visualization of our data is that, in essence, what we are showing is that resistance is a function of, if you will, in very pharmacokinetic terms, intracellular concentration times time. And the concentration being a function of how much HER2 you have on your cell surface to bring things in, and then how long it remains in the cell related to the efflux pump. I mean, that seems like a reasonable hypothesis. I think what our data also may suggest, and I think this may get to kind of more of a future therapy than a sequence question, is there are, at least preclinically, lots of drugs that are ABCC1 inhibitors. And so one could think about as a future direction a trial in which one looked at TDXD versus TDXD plus an ABCC1 inhibitor. I think that would probably be a very interesting question.
Yeah, I totally agree. And indeed, looking at this abstract, I also tried to look a little bit to the possible combination if this hypothesis is confirmed. I mean, we don't know very well what is the role of the flux transporter so far in clinical data in patients exposed to next generation of ADC, particularly to trastuzumab deruxtecan. But I think that this is something that we should consider a bit more in depth, particularly because if the first generation of a flux transporter inhibitor has demonstrated some disappointing results, we know that new TKIs, EGF1 receptor inhibitor, can potentially be combined with the novel ADC and provide some potentially interesting results.
And just to build on this, do you think this effect is specific to any payload, or this would be regardless of the type of payload? Does the type of efflux pump impact the efficacy based on the payload?
Yeah, it's a great question as well. You know, as my honored discussant showed, there actually is preclinical data with TDM1 suggesting that ABCC1 may be important there as well. That of course is a different payload. So this may be, I wouldn't go so far as to say that it's a constant, but maybe it's common.
Surat?
Yeah, hey, Surat Charnalapati from Sloan Kettering. Also a question for George, really beautiful work. I wanted to know if you guys, because you get both DNA and RNA, have looked at signatures at all in these NRF2 cases, and whether there are changes beyond ABCC, because this is a pathway that's quite important for a lot of different cellular functions.
Yeah, we haven't yet. And, you know, me putting NFE2L2 together with ABCC1 is somewhat of a stretch because NFE2L2 is a master regulator and it's doing probably 80 different things simultaneously. So I think that's well worth looking at. I think, you know, our claims data sets are probably a pretty crude place to do that. I think this probably should lead to some, you know, some preclinical cell line type work to see if it's real.
George, just following up on this. What we have been repeatedly told is only 1% to 2% of the ADC actually goes inside the cell. Yeah. So I'm surprised we didn't see any immune or any TME signatures. Any thoughts on that as to what's happening with immune, collagen, everything else in the TME?
Yeah, it's a great question. You know, in our list of genes that were there, Fc gamma 3A was there. So I guess you could make that argument, right? That that's sort of an immune type signature sort of thing. But it fell apart in multivariate analysis. It didn't split the KM plots at all. So and the immune signatures that we looked at, and we looked at several, didn't split the curves at all. I think this may, I mean, to my mind, what this suggests, of course, is that TDXD is slow chemotherapy rather than HER2-targeted therapy in a way. But it's also very, very clear that how much HER2 you have on your cell surface really, I mean, hugely affected overall survival in our cohort.
Just take one question online, and then we'll go to microphone one. And this is about TROP2 expression in SG. Thoughts on the association between TROP2 expression and efficacy, particularly why higher TROP2 expression does not correlate with efficacy, and I guess a correlate is with the ARID1 work that was shown. Any thoughts on potentially targeting ARID1 loss and improving the efficacy?
I think it's my question. So that is a point we focused for this therapy. So at the start point, we focus on the expression level of TROP2 in triple-negative cancer is around 80%, but on the contrary, hormone receptor positive is around 60%. And pastry, actually, we try to find another inhibitor which can enhance sacituzumab efficacy, and in that point, we luckily find the negative correlation between AR-ID1A and the TROP2, and so we focus on this mechanism. And so after the treatment, it looks like, so sacituzumab's payload is topoisomerase 1 inhibitor, and that causes activation of ATM. And so our hypothesis is that maybe increase the ubiquitination of AR-ID1A, and also that makes the degradation of AR-ID1A, and that changes the chromatin accessibility, and that can make the expression level of TROP2 go up. So this is our hypothesis, and it looks like so. So we are now doing further validation study. And luckily, he is my PI, so if we have another additional information, could you?
This is the, what we found is that this is mediated by the payload. So payload is induced double-strand breakdown, and that activated ATM phosphorylation that triggered ARD1A degradation. So this is a consequence of the enhance of the TROP2 expression. So what we hypothesized that ARD1A low population, the sesmocobidican could increase the target of the TROP2 that can enhance. But what we found that is efficacy is not strong enough as high TROP2 expressed cells. So that's why we proposed a combination therapy.
Great. Microphone one.
Do you think it's likely, unlikely, that the efflux pump described by Dr. Sledge is also going to export and inactivate the response to sacituzumab govitecan?
Can I take the question? Yeah, I showed some preclinical data that seems to demonstrate that another efflux transporter overexpression can be associated with sacituzumab govitecan resistance. So I think that this is an hypothesis that is absolutely worthy to be explored. If there are some reflux transporter for different specific payload or different efflux transporter can be involved in resistance to the same payload. This is a very interesting question and hypothesis, but so far we have some very limited data only in preclinical trials.
Two additional questions about the payload and the efflux pumps. The first is, in addition to ABCC1, have you also seen increase in expression of ABCC2 after TDXD administration? And the second question related is, in this data set, were all the post-treatment biopsies just after TDXD, or did patients get other treatments in middle?
So the answer to the first question is no. ABCC2, at least in our analysis, didn't show up as being important. The timing of the biopsies was all over the map. We are a commercial enterprise, so we run what people send in to us when they send it in to us, and so it's and we don't have any way of judging how many intervening treatments there were.
And final question, this is about HER2 mutations. Do you think an HER2 would work in tumors with HER2 kinase mutations in breast cancer?
Anyone's guess.
No, Barbara, do you have any thoughts?
HER2 mutation.
HER2
mutation. Okay. So that's a very interesting question. So far we have very solid clinical data in gastric cancer, in lung cancer, that show that HER2 mutation are associated with the efficacy of trastuzumab deruxtecan. And I say every time that I would like to see if we could have similar data also in breast cancer, and maybe some subgroup analysis in DESTINY-Breast04 and DESTINY-Breast06 can address this question. We know that HER2 mutation are associated with potentially with HER2 low, and so to perform this analysis, I think that can clarify in the next future if also HER2 mutation can potentially increase the efficacy of TDXD or other HER2 targeting ADC.
That was great discussion. Thank you to the panel members. Thank you to the discussant. Thank you so much for joining today.
Thank you.